So the airway can be compromised as a result of various things. It could be intraluminal disease, or it could be external bulk of the thyroid itself causing compression, or in this case, cord palsy. Swallowing, again, external compression can cause the problem, or it could be direct invasion of the vicinity. But you've got to think of the quality of life of the patient and how that's going to be managed. If the airway problem is the bulk of the disease, well, just because the larynx is invaded doesn't mean to say it needs to be removed. If you can debulk the disease in the thyroid, that's going to improve it. If the vocal cord is the problem, well, there's always a cordotomy.
Oh, sorry. Anyway.
We seem to have frozen the entire presentation now.
And stop video. The video, it's not because of that, is it? Is that now allow you to go on?
Oh, we have a technical hiccup. Okay.
I think we somehow knocked that button.
On the quality of life. And we need to think, actually, how do these patients die? This is the cause of death in Glasgow of thyroid patients. Now, some people say, oh, thyroid cancer, these patients don't die. That is not true. Some patients with thyroid cancer do die. But what do they die from? Well, the majority die during the period of follow-up from unrelated diseases. So that's good. But there are some, as you can see, 3% of our patients died from thyroid cancer. But they didn't die from the local disease. They died from metastatic disease. So doing aggressive disease control isn't necessarily going to affect their long-term outcome. Therefore, doing big local operations is probably not appropriate. You should consider doing the operation that gives the patient the best quality of life rather than just take out disease because it's there. So if you've got a patient whose cord palsy is causing their airway obstruction or whose bulk of disease is causing their airway obstruction, debulk the disease. Consider doing this. This is a vocal cordotomy. You cut the posterior third of the vocal cord. It actually doesn't massively impact on the patient's voice. They're not going to be able to sing in a concert, but they will be able to speak very well, and they're unlikely to aspirate, but it can significantly improve their airway. Tracheal invasion, something like this, might be resectable, but in the context of other disease, probably not. But you can control this. In this case, no real treatment would be required other than debulking the surrounding disease, potentially radioactive iodine. In this case, no. This is a patient with airway obstruction, very little airway left, large volume disease. Do you do a tracheostomy? Well, no, you don't really want to do that because that's going to impact on the patient's quality of life. But you can debulk this. There are various techniques. You could use microdebrida. Here we're using suction monopolar, reduce the airway down, and then ultimately we went on to do a tracheal resection. Local disease, minimal morbidity. We've not cured the patient, we know that. But we've maintained their quality of life without doing a significant organ resection. If you can't resect the trachea, you can always stent it temporarily, enable you to do surgery and then use additional treatments. All these are options that are on the surgical table if you've got a patient with airway obstruction. How about the esophagus? They're all men, despite the fact it's more common in women. The men seem to have had more advanced disease at presentation. I think the women take better care of themselves. So, 85-year-old male, previously fit and well, now presenting with dysphagia. Can't swallow. No airway issues, no vocalization issues, no swelling in the neck. Actually got referred to the upper GI surgeons thinking he must have a stenosis. They identified that this seemed to be external compression with apparently normal laryngeal function, and certainly I can confirm that, normal vocal cords. But large mass involving the postcricoid in the esophagus. You can see it extending down in the top right-hand corner. So this is significant esophageal disease, but localized disease. Now, in order to surgically cure this patient, I would need to do a laryngopharyngectomy and then reconstruction either with a gastric pull-up or local flaps. That's a massive operation for an 85-year-old. Now, the esophagus generally is resistant to invasion, and you can resect the esophageal musculature as long as you preserve the mucosa. But I don't know any surgery that I can realistically do for this particular patient that's going to enable him to be able to swallow and vocalize at this stage. So we need to think, is there something else that we can do? We need to make sure we maintain as good a quality of life as we possibly can. And I don't think that this particular patient is best served by taking his larynx, pharynx, and probably most of his esophagus out. So back to Carlo. He's had his external beam radiotherapy. He's now walking. He's scheduled for surgery, take his thyroid out. A week before we're due to do his total thyroidectomy with a view to radioactive iodine, he collapses again. He's now doubly incontinent, can't get off the bed. I get phoned up on a Sunday. Nick made the big mistake a few years ago of giving me his mobile phone number. So I phoned him straight back and announced, yeah, me doing an operation isn't going to help this. Professor Reed, over to you.
So the traditional treatments that we've used have been really very disappointing. Systemic anti-cancer therapy, doxorubicin, cisplatin, really, I will show you on the next slide, very disappointing. Very poor response rates, short duration, and really the game changers over the last 10 or so years have been the tyrosine kinase inhibitors, now known as MKIs, because they don't just hit one pathway, multiple pathway MKIs. There are lots of them around, but in fact in the UK, and I can just focusing on our own practice here, there are only 3 that are approved and licensed for differentiated thyroid cancer. Sorafenib was the first one, lenvatinib the second one, and cabozantinib has recently become, well, it's not actually approved by NICE or SMC, but is starting to be established and you can get it. And then one mustn't forget that there's the recent introduction of the RET and NTRK inhibitors. But as we saw at the beginning of today's presentations, in adults, it's fewer than 10% of tumors exhibit a RET or an NTRK mutation in differentiated. Now, medullary is quite different. Medullary, we're excluding that. And similarly, vandetanib, which is used in medullaries, is not really under consideration here. And this is really just to highlight, look at the rings, the none, and follow the lines along. 90%, 80 to 90% of patients have no response to treatment. Very disappointing. We used it, but by and large, we were treating ourselves rather than treating the patient. We did it because we had to offer something. And so along came these new TKIs with their whole new range of opportunities. And there are the licensed indications, and the licensed indication really is radioiodine refractory disease. Now, we can have a debate about what we define as radioiodine refractory disease. The simplest definition is that the patient has a dose of radioiodine and the post-treatment scan shows no uptake. That's unequivocal. But the regulation does allow you to use lenvatinib when patients have had more than certain cumulative doses, because once you get above 5 or 6 doses of radioiodine, you start to see serious risk of late side effects, leukemias in particular, myelodysplastic syndromes. And then what I call, I suppose, the softer indications, where a patient is considered unsuitable for radioiodine, maybe because he or she can't swallow, or there may be genuine reasons why they may actually mobility, for example. They've got, when you have radioiodine, you have to be in confinement in a solitary room. You've got to have a degree of continence and so on, and a sufficient mobility to be left on your own. Although, of course, the nursing staff will come in and monitor the patient, the nursing staff can't be in there all day long. There are rare contraindications. And then there's, of course, the patient who's unfit for whatever reasons, unsuitable or unfit for thyroidectomy, because there's no point giving radioiodine if the thyroid is still present. You give the iodine, it'll just go straight in the thyroid. It thinks it's Christmas and New Year, and it just grabs it, whereas the metastases have very little uptake. You've really got to give 2, 3, or 4 administrations before you start to see this. And then there are patients who've got relatively poor performance status who may be unfit for a general anesthetic or may have other comorbidities. Now, they may be questionable candidates for a TKI. And then I think what was really being hinted at earlier was this neoadjuvant use, which I will come back to. But the neoadjuvant use is starting to gain ground. It's not licensed. And at the moment, it's really all sort of anecdotal, small series. So one of the big drivers really has been the introduction of, as again this morning, I'm not going to spend a long time with this, but really just highlighting that there's BRAF, the RASes, HRAS, NRAS, KRAS, RET, NTRK, a number of, and TERT have really changed the way we practice. And the way they've changed it is because some of these mutations now have a candidate drug that you can use. Not all of them, but the BRAF, we know that lenvatinib has some activity, but more recently, dabrafenib and trametinib. So we've got these markers that we can now do, and thankfully in Scotland, in the last month or two, these are starting to come through standard. I mean, we've been very envious of the genomic hubs in England, which have been offering this for several years. So I've just highlighted the big three, the key 3 ones for us: sorafenib, lenvatinib, cabozantinib. But as you can see, there are a whole host of others. And in fact, down towards the bottom, we've got dabrafenib and trametinib, and then selumetinib was the drug that disappointingly was hoped to reverse the sodium iodide transporter system, which would overcome resistance, radioiodine refractoriness. And in animal models, it does that. And there are some patients where it seemed to have had a benefit, but the trials so far have been terribly disappointing. And as it's written at the bottom, we can add in RET. So the first of these was the DECISION trial with sorafenib. It was the first widely available TKI in differentiated thyroid cancer, mainly affected, obviously, because it's sorafenib in BRAF mutated patients, although we weren't routinely testing at that point. Moderately active, the first of these for many of us. I mean, some of the other tumor types had availability of TKIs, but for us, it was a huge learning curve. It's the first time we'd used one of these drugs. Instead of the traditional nausea, vomiting, alopecia, we were seeing completely different side effects, which I'll show in a minute. But this was why it generated a lot of excitement. As you can see, 10 months as opposed to 10.8, nearly 11 months, as opposed to 5.8 months progression-free survival. Not huge, but certainly a positivity, a real indication that something was happening. But the next study was the SELECT study with lenvatinib, which is a dirtier drug. So it's probable that sorafenib is more likely to be a pure BRAF inhibitor. But lenvatinib is a dirtier drug. It's really a multiple kinase. It hits multiple pathways, which is probably why it's so much better. There's never been a direct comparison between the two drugs, but we do see better outcomes, better response rates, more durable remissions. And I mentioned the patient that actually transferred up from the Royal Marsden, who's been on the drug about 12 years. But again, there was this learning curve for toxicities. And here in Scotland, we are able to choose and use both these drugs, whereas in England and Wales, NICE only allows you to use one. There is I think it's a 90-day window. You can actually switch if there's toxicity or things don't work out. And this was, I was actually at ASCO, I think it's 10 years ago when this was presented. And it really was quite jaw-dropping to see this 19 months progression, or 18.3 months, as opposed to 3.6 months. And you can see, that is making a massive impact. And look at the tail going along there. There are 40% of the patients still alive. And this is sort of mirrored our experience. So lenvatinib really was a game changer. And given the choice between the two, I think nearly everybody would go for lenvatinib. Beyond lenvatinib, well, the Exelixis Cosmic 311 study was recently presented. This was using cabozantinib in patients who'd been on lenvatinib. And you can see that progression-free survival does show a benefit, although the overall survival, they're fairly parallel. But it indicating that you can get a second wind, as it were. So the importance really of checking the molecular profile, and there are these newer drugs which are coming through, which again are only available on an individual patient basis. So molecular testing should have been available for a long time, but we've now got it, and it has been available in England. And these RET mutations and fusions and NTRK are very rare or very uncommon in adults, much higher in children, although I've yet to see one, but they certainly up to 30%, it's claimed. But one of the difficulties is, when do you test? Do you use the original, if you like, the first presentation tissue, or do you test them at the time of relapse? And if you do test them at the time of relapse, do you use the original tissue, or do you actually go for fresh? And probably the correct answer would be to get as fresh a tissue as possible. It's my impression that you don't see so much evolution or transformation in papillary and follicular thyroid cancers. There are many other cancers, and I treat neuroendocrine tumors, and there you can quite often see over 7 to 10 years significant changes. So you go for a fresh biopsy. But with these, they probably don't emerge. Medullary may be different. Medullaries, you can get these gatekeeper mutations that can come along, and you can get some very strange things happening. So my impression is that they probably don't emerge or evolve that much. I think they can do that, but it's not sort of standard. So the monitoring of these drugs is a huge issue. They're very different toxicities: mucositis, diarrhea, skin rashes, weight loss, hypertension. You get the myelosuppression. Proteinuria, you have to check, you should be checking urine dipstick for protein. Nephrotic syndrome is very rare. I've only seen it once, actually. And ECG changes with prolonged QTC. So you've got to sort of monitor all these things. Very different from traditional oncology. And obviously we just do the standard hematological things as well, but blood pressure testing has to be done prior to each visit. It's important that you do check the dose, dose adjustments. You need to, particularly if they get severe diarrhea, by giving them a short break, and it has to be a very short break, you can reset the clock and the bowel habit tends to recover. But prolonged breaks are very bad news. And as I alluded to earlier, I think in the anaplastic tumors, any break or interruption is potentially, I think, a really serious situation to try and avoid. Early responses do tend to be seen, often within 8 weeks. There is this recognition of pseudo-progression. You need to be wary of that you don't stop the treatment just because you think it's progressing. So importance of getting good radiological review. Patients in the trials were imaged every 8 weeks, but to try and pick up these early responses. And in real life, we're probably more likely to do it every 3 months because we can't afford to do it every 8 weeks. Thyroglobulin is also useful, but in tall cells, and it's my impression that in tall cell tumors and some of the others, they may not make thyroglobulin, so that it may be of limited value. But we have a number of examples of patients who have recurrent disease and their thyroglobulin either doesn't change, or there's actually one mutual patient we have at the moment whose thyroglobulin over the course of about 9 months went 0.3, 0.6, 0.9, 1.2 to 1.6. And in her, it actually was indicative of a recurrence. And Omar's just taken out her nodal disease. So hopefully the thyroglobulin will come back down. But, so in an individual patient, these normal levels may actually be indicative if you see this constant rise. And then obviously thyroglobulin antibodies in some patients, rising or emerging antibodies is bad news. So just a couple of slides, really. I have a feeling they probably wanted more on this, but the neoadjuvant setting, this is novel. This is, so far, there's lots of anecdotes or series of 2, 3, 4, 5, 6 patients from major centers. And it may be useful because you may be able to start some treatment, and then there may be opportunities for delayed surgery, a concept that's well described in ovarian cancer with neoadjuvant chemotherapy and delayed surgery. It also gives you an opportunity to look to see whether the metastases are, if you start the drug and the metastases, although there may be local or some control in the neck, if the metastases are not responding, there's probably little indication to use to consider surgery. And then we have this sort of big headache. What do you do if you've got a patient who's had the disease resected? So I've managed to control it. Omar's managed to go in and cut it out. Do you continue with the TKIs? Do you revert to orthodox treatment, particularly if it's a well-differentiated tumor? And I think these are questions that we probably don't know the answers to. And I think there's a lot more to be discussed there. And I think you probably have to do what you do on an individual basis. I was stumbled across this paper that actually came out last year, which was from Japan, a preoperative neoadjuvant targeted therapy with lenvatinib. And I've put the blues asterisk there because, interestingly, you see the best responses were achieved between 1.7 and 4.7 months. So really quite early, with an average of 2.9. Again, there were problems with toxicity, but the drugs were tolerated. But, they saw benefits, they saw responses. So in selected, I think it has to be discussed at the tumor board, the MDT, and in selected cases, it is reasonable to consider these approach. And what we really need is a registry or a database, so we collect all these. And none of us seems to have the time to do these sorts of things. So back to you.
Okay, so guess what Nick did? He's just mentioned it, neoadjuvant TKI. Which one did you use, Nick?
Lenvatinib, I tend to use.
It was lenvatinib. Spinal cord metastasis responded. He got back up on his feet. He's doing really well. He's doing so well that we're sort of saying, well, do we need to operate? And after 12 months of saying, well, do we need to operate? He eventually turned around and said, well, get your finger out, do the operation. So we went in. Total thyroidectomy. Cleared the disease from the neck. He also had a node in the neck, which we took out at the same time. But what's the principle in this situation? Normally, when you go in and do an operation, you want to clear as much disease and as much potential disease as possible. So I'd probably have done something like a total thyroidectomy and central compartment clearance. He didn't have any obvious nodes in the central compartment. But because there's lateral nodal disease, you normally do that because you've got to presume it's going to be there. We just don't know about it. But we're not going to cure him. He's still got his spinal metastasis. And no matter how good Professor Reed's drugs are, they're unlikely to cure the spine. So should we really be doing more aggressive local surgery, potentially increasing the risk of hyperparathyroidism, small increase in the risk of nerve palsy by doing a central compartment clearance? Or should we simply go for the main sites, take the thyroid out, do a selective neck dissection involving that area of the neck? We don't want this patient to have issues with a chyle leak or with any form of accessory nerve injury. We want to minimize the complications and surgical morbidity. And these are the principles you've got to consider when you know you're not going to cure the patient. You would not resect a recurrent laryngeal nerve if it was functioning preoperatively, even if it meant getting local disease control, because it's not going to cure it. You're going to give that patient a cord palsy. Yes, we can manage it. We can do medializations. We can do reconstructions at the time. And if you do get a patient with a cord palsy, I would suggest that those patients, you should medialize early. Because if you don't medialize them early, after they've developed it, they can develop aberrant speech patterns, supraglottic tension voice, and it takes the speech and language therapists months to retrain them. So if you do get a vocal cord palsy after any thyroid surgery, if you know it's going to be permanent, inject early and then involve speech and language therapy. You're going to get a much better long-term result by doing it that way, rather than waiting for the speech and language therapists to come back and say, you might want to consider this. The main aim is to reduce the chance of developing disabling symptoms. You want to give this patient the best quality of life as long as is practicable, because we're not going to cure it. Always remember, recurrence does not equate to mortality. Yes, you can have local recurrence. They've got disease anyway. And as long as that recurrence isn't symptomatic, you can keep an eye on it. If it's stable, just observe it. If they get symptomatic disease, well, treat those symptoms. And that can be either surgery or you can intensify the oncological treatments. Now, I'm not saying leave large amounts of disease behind when you're going for your surgery. You don't want to do that, but take as much as is practically possible by minimizing the consequences. And above all, consider the morbidity that you're creating with your surgery. You've got to justify that you may cause this patient a problem and that ultimately it's going to give them benefit. We did his surgery. And we're then, well, what do we do now? Professor Reed.
Well, yes, it was a difficult, I'll go back. It was a difficult, I didn't make a slide with this, but it was a difficult discussion or choice, but I felt it was worth giving him a dose of radioiodine. And perhaps a little disappointingly, the post-treatment scan doesn't show as much uptake as I would hope. So I have a feeling that, we'll have to wait and see, but I have a feeling he may well finish up back on a TKI sooner rather than later. But we'll see. It's still early days, and I think we've got to see what happens. So I think my final two slides, really, it was just to sort of highlight that TKIs have now established themselves, certainly for recurrent disease, and very selectively in the neoadjuvant setting, but it has to be with very careful individualized discussion. There are side effects, particularly things like the diarrhea can be very troubling. I've listed those 7 side effects there, and we actually did publish in the, I think, Clinical Oncology about 5 years ago, some UK guidelines on how to manage the particularly lenvatinib toxicities. So, you know, they need to come to specialist clinics, and the input of the role of the CNS is very important in helping to manage that. You do need to consider dose modifications and reductions. It is possible to keep some of these patients on treatment for a very long time, but if they become intolerant, you have to then scratch your head to see what else is around. At the moment, I don't think we know that there's a maximum duration, and it may be possible if there is, and, you know, to think about re-challenging them if you did have a break. And resistance probably does happen, but again, you know, our experience is still, they're relatively new drugs, so we're still learning about them. So the TKIs have offered hope after radioiodine or in the neoadjuvant setting. We have seen unprecedented responses compared to our historical treatments, sometimes long-term. Many of these toxicities have been new. I mean, we're now familiar with them, but it's been an interesting 10 years learning how to manage these. You know, we're way behind the melanoma people and the renal cell tumors who had some of these drugs very early on. Molecular testing really should be a standard of care. In fact, I think when I drafted this slide, it still wasn't a standard of care in Scotland. But one good thing about the last month or so is that we're now seeing it. I've already highlighted on when you do the testing. Do you do it up front or do you do it at time of relapse? We still need new drugs. Dabrafenib and trametinib do look as though in the BRAF mutated patients, they are very, should we say, very promising. There's I can't even remember how you pronounce it. There's another new pair, I think encorafenib and Bini something, I can't remember. These are being used in melanomas which have BRAF mutation, and there is some data emerging. They're not available, though I'm not even sure whether we would get them on an IPTR basis. But it's been an exciting decade really to see these new changes which have altered our practice and maybe will alter the surgical practice as well. So I think, as they say on that famous television program, it's goodbye from me, it's goodbye from him. Thank you for your attention. So it was unrehearsed. It probably was obvious.
Fantastic. That's actually one of the best in times. Great. I'll just check whether there's any questions.
You've got the star coming on next, Kate.
You send a recorded talk, but that's initial. There's some glitch in the mic.
I think we managed to knock that
Yeah.
button somehow. I don't know how we did it.
Sorted out. Thanks.
Yes.
Good. I think that's
No
fine.
questions?
All
Wonderful.
questions, yeah.
Excellent. Well, thank you very much.
That's brilliant, thank you. Yeah. good work.
Hi, thanks for that talk. I was just actually wondering about like the tissue quality after somebody has had a TKI inhibitor or immunotherapy, like you going in and doing surgery after neoadjuvant treatment. What's it like?
Doesn't seem too bad, to be honest. I've done it in a few cases now, and there's no real surgical problem. Yeah, I mean, it's no more or less complex than any other case. It's more the disease that causes the complexity, I think, rather than any local reaction or anything like that.
There is an issue with conventional chemotherapy, and then obviously a field that's not directly related here, but for example, in ovarian cancer, where neoadjuvant chemotherapy with cisplatin and paclitaxel has been used. Oh, is this one not working? Sorry. So there has been issues in other tumor types with traditional chemotherapy. In ovarian cancer, where they've used neoadjuvant chemotherapy, they do see quite a lot of fibrosis. All right. Oh, you can stop. So I think that may well be something specific about ovarian cancer, which is a very different tumor. And so far, it does seem that I think for the TKIs, I haven't seen much in the literature to suggest that it is a problem. But it's a very good question. And but if you've not seen it so far, then it probably means it's not a big issue.
Don't get me wrong. I mean, as soon as I have a tricky case, I'll just blame it on what you've given them, Nick.
Good excuse you to moan.
Absolutely. Okay, I'll leave you to it. Thank you very much.
Brilliant. I think the next talk is this sharing? You need to share it.
Good afternoon. Thank you very much for this presentation.